Good morning. I'm Rajesh Shah. I'm a thoracic and transplant surgeon in Manchester. I'm also the president-elect of SCTS. I just want to thank the Egyptian Society and also, of course, the SCTS for inviting me to give this presentation, and it's a great pleasure to be part of this course, really. I'm going to be talking about surgery for lung cancer. Uh, Now, I'm going to present five groupings in lung cancer to discuss the workup, the staging, and the management. The reason for grouping them in different subsets is to try and standardize the workup, the assessment process, the staging process, so as to achieve consistency in the decision-making process and thereby the outcomes in the management of lung cancer. Now, I work in Manchester. We serve a population of 3.2 million. We do about 630 lung cancer resections in a year. And so for us, it is quite important to have a degree of standardization in the staging, diagnosis, and the assessment process in the management of lung cancer. So group one is a peripheral tumor with normal hilar and mediastinum with no evidence of distant metastases. So these are usually obviously stage one tumors, and it also includes tumors with a pulmonary solid component within the GG of 5 millimeters or more. So early stage lung cancers, consider doing a CT scan, consider doing a PET CT, consider doing a CT guided biopsy if possible, or to do a radial EBUS bronchoscopy to achieve a diagnosis. All these patients will have standard workup in terms of spirometry, including transfer factor. We introduced shuttle walk test early in our assessment process and routine cardiological examination. Echocardiogram is done in only very specific cases as outlined below. Once the CT PET and the appropriate workup is done, they're all discussed within the MDT. The second group is tumors, central tumors with evidence of N1 lymphadenopathy with normal mediastinum on staging CT with no distant metastases. Now, it's important to recognize that in this group of patients, the PET CT has a 15% false positive rate and about 25% false negative rate for N2 to N3 disease. And hence, in addition to CT PET, staging EBUS is considered, and this is the staging EBUS and all appropriate lymph nodes to rule out N2, N3 disease needs to be considered. Now, once all these tests are done, again, they're all discussed within the MDT. And in Manchester, we have a standard prehabilitation protocol, which includes a smoking cessation, an exercise program, and addressing the nutritional requirements as part of any patient who is undergoing radical treatment for lung cancer. Group 3 is patients with primary tumor and discrete mediastinal lymphadenopathy with no distant metastases. Again, it's important to recognize that the false positive rate of 15% with CT PET and a false negative rate of 25% for N2, N3 disease, and hence following CT PET, staging EBUS, is considered, and in addition to that, a contrast enhanced brain imaging, either CT or MRI, is considered. This physiological workup is standard as in the other two groups, and once this workup is done, these patients are discussed within the MDT. And again, once again, they all follow a common prehabilitation and optimization protocol following assessment by the chest physicians. Group 4 is the conglomerate and invasive nodal malignancy on staging CT. These are unlikely to be candidates for surgery, and the idea is just to get tissue diagnosis. So following CT PET, an EBUS and an EBUS guided biopsy is considered to get adequate tissue for further oncological management. Group 5 is patients with distant metastases on staging CT. And again, in this group of patients, the primary issue is to get a histological diagnosis, followed by appropriate molecular staging for consideration of oncological management. In majority of the cases, there are some cases with oligometastatic disease, which can be considered for surgery, and we'll be discussing that later on. The primary reason, as I said, to group them into separate groups is to standardize the preoperative workup, staging, and assessment process. And the reason is that this part of the process greatly influences the resection rates and as we know, the resection rate varies in different parts of the country and between different countries, and the preoperative assessment staging plays a major role in these differential resection rates. I'm sure this has been touched upon before, but just to mention it, there are 3 components when we carry out risk assessment for surgery. Number 1 is to estimate the perioperative mortality, which is done using a thoracoscore. As we know, thoracoscore is currently recommended, though is not very good and has got some limitations. The second component is to assess the risk of the postoperative cardiac event, which is mainly done using American Heart Association guidelines. And the third risk assessment component is to estimate the postoperative dyspnea, which is done using estimation of the postoperative predicted transfer factor and spirometric assessment. This is the revised cardiac risk index. As we know, the more the number of factors, the higher is the risk of major cardiac complications. And the various risk factors are as stated in the slide, which includes any form of thoracic surgery, ischemic heart disease, congestive cardiac failure, cerebrovascular disease, insulin-dependent diabetes, and preoperative serum creatinine level of greater than 177. When you have more than 3 cardiac risk factors, it is recommended that a cardiological assessment takes place. This is variable. We don't necessarily do it in our department, but this is what the recommendations are. The risk assessment for postoperative dyspnea is by using spirometry and transfer factors, studies in all patients, and stratify them into 2 groups. When the predicted postoperative FEV1 is greater than 40% and the transfer factor is greater than 40%, the risk of postoperative dyspnea is low, and these patients can undergo surgery without any issues. When the predicted postoperative FEV1 or the predicted postoperative transfer factor is less than 40%, it is recommended they have further functional assessment, either in the form of shuttle test or stair climbing or CPEX, thereby facilitating them into stratifying them into the moderate risk or the high risk group, and thereby facilitating consent and decision-making process within this group of patients. As I said, in our center, we introduced the functional assessment much more earlier, and that is primarily because we serve 10 or 12 different hospitals, and we have noticed that there is variation in the lung function assessment in different centers. The postoperative pathway is, again, there is a lot of variation in different departments, but in general, there are 3 pathways for for following surgery for these group of patients. One is the uncomplicated group of patients or low risk patients, which can go straight to thoracic surgical ward with some form of monitoring. There are patients who are intermediate to high risk, and some of these factors are highlighted in this slide. Especially patients with borderline lung functions, renal dysfunction, or cardiac compromise. They need HDU level care. And of course, there are some highly complex patients who might need level 3 care. Now, we all know staging influences survival. Staging also influences how we stratify them and select different modalities of treatment. This is the 7th edition, which originally was utilized in 2007, 2008. Currently, everywhere in the world, I think the 8th edition is being utilized, and we will touch upon it later on. This is the 8th edition of lung cancer staging, which is now widely utilized across the world in physicians involved in the lung cancer management. The major change is in the T status. As you can see, the T1 is stratified now into several groups, with T1A, less than 1 centimeter tumor, T1B 1 to 2 centimeter, T1C 2 to 3 centimeter. The reason for doing that is there is differential prognosis in each of these separate group of tumors. Again, and nodal disease has been classified into N1A, N1B. N1A is single station N1 involvement, N1B is multiple station N1 involvement, and N2 is again classified into single station with no N1 involvement, or single station with N1 involvement, or multiple station. And again, for reason for doing this is, you will see, as I will show you in further slides, there is differential prognosis in these patients. Again, the metastatic disease is classified into M1A, M1B, and M1C. Again, this is related to slightly differential prognosis in each of these groups of patients. This is a slide showing differential prognosis and outcomes, especially as you go from T1 to T4. As you can see, T1A, the 5-year survival estimated is almost 90%. T1B is around 80%. T1C is 76%. And again, there are some new T categories, the minimally invasive carcinoma and carcinoma in situ, and also carcinomas with visceral pleural invasion, which automatically becomes T2. This is a study which shows the effect of surgeon volume on procedure selection. In general, there is a relationship between surgeons doing a higher volume of lung cancer operations. They tend to do more complex resections, they tend to do more lobectomies, and less of pneumonectomies and more segmentectomies. There is also a relationship between the volume of operations which the surgeon does, or the surgeon specialty, and the outcome. And in general, this has been established in other surgical specialties as well. The more the volume, the better are the outcomes. This is the impact of MDT care on the quality and cost of care in lung cancer patients. And this is primarily because of better staging, consistency in application of guidelines, lowered cost, less time, etc., which leads to better outcomes in patients with lung cancer. And this again is adopted widely in most of the centers around the world. So this is the eighth edition of TNM staging, thereby classifying patients into several different groups. Stage 1A, Stage 1B, Stage 2A, Stage 2B. Patients, if fit, are considered for surgery. There is no controversy about that. I think Stage 3A is a very heterogeneous group, and selected patients within stage 3A in the context of multimodality treatment will benefit from surgery. And as we move further along in stage 3B and in stage 4, again, a very, very select group of patients may be considered for surgery. So early stage lung cancer, stage 1A, stage 1B, lobectomy still remains the standard of care. Segmentectomy can be considered in selected cases. Wedge resection in very, very super selected cases, and majority of these patients will have minimally invasive surgery, either with VATS or robotic surgery. There are certain cases which can be considered for sublobar resection, either segmentectomy or, as I said earlier on, wedge resection in very, very select cases. Segmentectomies is clearly better than wedge resections. Peripheral tumor less than 2 centimeters in diameter, predominant ground glass appearances on CT scan, older patients, patients with compromised lung cancers or lung function, and patients with synchronous tumors. There's no robust data in favor yet for this sublobar resections, but as colleagues are aware, there are 2 big studies, randomized studies going on, and we await the results with interest. As we move along to stage 2A and stage 2B, once again, lobectomy remains the standard of care. Some cases may require pneumonectomy or bronchoscopy sleeve resections. As and when possible, pneumonectomy should be avoided unless absolutely necessary, and if the complex resections are not possible. Adjuvant chemotherapy is used in selected cases, especially in tumors which are more than 4 centimeters in diameter, or in patients with N1 or N2 disease. As we move along, the higher the stage, the lesser is the chances of minimally invasive resections. But as we all know, it depends on the experience of the operator. As long as appropriate oncological clearance is achieved, minimally invasive technique can be considered in some of these cases. Complete resection is what we should set out to do, and it's defined as free resection margins proved microscopically, systematic nodal dissection or lobe-specific nodal dissection to be considered, no extracapsular nodal extension of the tumor, the highest mediastinal node removed must be negative. I think my colleague is going to be talking, Carol is going to be talking about N2 disease, so I'm not going to go into detail with N2 disease, but just to say there are different approaches. Again, surgery forms a key component, and multimodality approach is to be considered. The nodal stratification is quite important, and the reason why it's important is because the survival curve is different. As you can see, the blue line represents N1 disease, or just in the hilum, single hilar lymph node metastases. The prognosis is better than when you have multiple hilar lymph node metastases. And when you have single N2 or multiple hilar lymph node metastases, the survival curve is almost similar. And as we have multiple lymph nodes involved in multiple stations in N2 disease, the survival is even worse. I think, again, Carol will be talking about the N2 disease, but it's important to note the meta-analysis which was done by Eric Lim in trials where patients received surgery as part of trimodality treatment. The overall survival was better than chemotherapy and radiotherapy alone. I'm sure this will be elaborated further. Again, this it's a complex area of N2 disease. It's not a homogeneous disease entity. All these patients should be discussed within the MDT, and best multimodality treatment in the context of surgery, along with surgery, should be considered. It's important to recognize salvage surgery is the only option sometimes in patients after uh, curative full dose chemoradiotherapy who may not respond fully or who recur after curative chemoradiotherapy. These are patients with M1 disease. A very selected group of patients may benefit from surgery, especially with single organ metastases in either the brain or the adrenal. Again, it needs to be considered in the context of systemic therapy. There are guidelines, the European guidelines on intraoperative lymph node staging. Some form of intraoperative staging is absolutely mandatory. It may be systematic lymph node dissection or a lobe-specific lymph node dissection as recommended by ESTS. This is a randomized study looking at the impact of systematic lymph node dissection on survival. If patients are staged appropriately and thoroughly prior to consideration of resection, then the view is mediastinal lymph node dissection does not impact on survival. This is a paper showing the more the lymph nodes are sampled, the better the survival. Is basically related to lymph node stratification and into appropriate stages, thereby influencing survival. In our center, for N0 disease, we consider mediastinal lymph node, systematic mediastinal lymph node sampling. For N1 or N2 disease, we consider systematic mediastinal lymph node dissection. Just to touch upon, this is a group of patients which are increasingly being seen as CT screening is being introduced across various parts of the world. There's a spectrum of ground glass opacities which are seen on CT scan, and it varies from pure ground glass to semi-solid lesion to solid lesions. And they can be categorized into various different categories: pathologically, adenomatous hyperplasia, adenocarcinoma in situ, minimally invasive adenocarcinoma, and lipidic adenocarcinoma. Not all of these patients require surgical intervention, as some of them behave in a very, very indolent fashion. So this is the Japanese colleagues recommending which one of these GGOs should be considered for surgical intervention. All of these require a follow-up initially at 3 months repeat CT, followed by annual CT. If it's a pure GGO and the solid component is more than 5 millimeters in diameter, surgery should be considered because the chances of invasive adenocarcinoma is quite high. If it's a part solid GGO, which persists on CT at 3 months and on repeat CT shows a solid component of 5 millimeters or more, they should be considered for surgery. Or if the size increases to 15 millimeters or more, should be considered for surgery. And part solid GGO, where the solid component is greater than 5 millimeters, it should be considered for surgery because the chances of invasive adenocarcinoma is quite high. This is again the Japanese guidelines on what kind of surgery should be considered in GGOs. So if they're more than 3 centimeters in diameter, then a standard lobectomy is what is advisable. If they are 2 to 3 centimeters in diameter, then what the Japanese colleague use is the CT ratio, which is the consolidation to tumor ratio. And depending on that, one can consider either a segmental resection where the CT ratio is less than 0.5, okay, but if it is more than 0.5, then standard lobectomy is considered. And if they're less than 2 centimeter in size and the CT ratio is less than 0.25, very select group of patients may be considered for wide wedge resection. But this is the subject of discussion, and also as the evidence of the randomized trial comes through, these guidelines might need to be revised. Salvage surgery, as I talked about, in select group of patients after they've either failed chemoradiotherapy or recurred after chemoradiotherapy, can be considered. They are quite challenging resections to do, but they can give reasonable survival, as there may not be any further options. Just touching upon oligometastatic disease, there are ESMO guidelines for management of these patients. And in select group of stage 4 patients who had 1 to 3 synchronous metastases are present at diagnosis, following systemic therapy, some form of local consolidative therapy may be considered, may be high-dose radiotherapy or surgery. In some patients with limited metachronous disease, again, following systemic therapy, some kind of radical local radiotherapy or surgery may be considered. This is as a result of a study which was done, published by Gomez et al. In 2019. In graph A, we can see patients with stage 4 disease who received some form of consolidation therapy, maybe radical surgery or radiotherapy, had better survival and better overall survival. This is again a subject of further investigation and research, and I think Eric Lim is planning some kind of trial on this stage 4 group of patients called Ramon trial. So the current role of surgery, future looks bright. Screening is going to evolve, is already evolving in various parts of the world, and it'll only get implemented even more in the future, in the next decade or so. The final aim is complete resection. Early stage lung cancer, surgical resection is standard. Locally advanced lung cancer is multimodality treatment with surgery forming central in some of these patients, salvage surgery in selected group of patients. And as I said, oligometastatic disease is considered in very highly selected group of patients with single metastasis, and is something which will be looked at more carefully in the future. I think this was in 2009. Peter Goldstraw said surgery is the only prospect of cure in a patient with lung cancer. I think we need to reflect on that, need to revise that. Surgery in the context of multimodality treatment is the only prospect of cure or prolonging survival in patients with lung cancer. Thank you.